Welcome to today's MESUD Learning Community webinar. I'm Kristen with CCSME, standing in for Bethany today. Today we'll be hearing from Gordon Smith and Dr. Adrienne Carmack on a discussion about the recommendations from the special report by the Maine Accidental Drug Overdose Death Review Panel of Adolescent Cases. I'll be supporting today's webinar along with my colleague Casey. I have just a few notes before we begin. First, neither the presenter nor the planners have any relevant financial relationships to disclose. This activity has been planned and implemented in accordance with the accreditation requirements and policies of ACCME through the joint providership of the Hanley Center for Health Leadership and Education and CCSME. The Hanley Center is accredited by the MMA Committee on Continuing Medical Education and Accreditation to provide CME for physicians. The Hanley Center has designated this activity for one AMA PRA Category 1 credit. The opinions expressed by the speaker in this webinar series are their own and do not represent a position of CCSME. Recording and live stream transmission of this webinar without consent is not permitted. We will have a few minutes at the end of the presentation for questions and answers, so please hold any questions until that time or place them in the chat feature in Zoom. Slides and materials from today's webinar will be sent out in a follow-up email. And now I'd like to give a quick introduction for our speakers for today. Gordon Smith was appointed by Governor Janet Mills as Director of Opioid Response in January 2019. He is responsible for coordinating and directing Maine's response to the opioid crisis, including prescriber education and reduction of opioid prescribing, prevention and treatment of substance use disorder, and harm reduction strategies. And he does many things in the course of doing that work. And Dr. Adrienne Carmack began serving as the medical director of the Office of Child and Family Services, the Maine Department of Health and Human Services, in March of 2020. In this role, she offers clinical support to the state child welfare system, as well as children's behavioral health and early care and education. Dr. Carmack also continues to work part-time at Penobscot Pediatrics, part of Penobscot Community Healthcare, and FQHC in Bangor, Maine, where she has worked since 2007. And with that, I will hand it off to our presenters today. And I think, Gordon, you're going to kick things off for us.
I am, and thank you, Kristen, and good afternoon. I know over almost all of you, and it's a pleasure to see you all and to have a few minutes today to talk about this report. I'm going to kind of tee it up by talking about the panel itself and the statute that we work under. And I'm so appreciative that Dr. Carmack has really done the heavy lifting here and prepared the slides and has even some other guests with us from the Department of Education, OCFS, the Children and Behavioral Health Unit at the Office of Behavioral Health, and the CDC. And so they're going to do the guts of this presentation. But the Overdose Review Panel, which I'll refer to it rather than using the formal title, which is the Maine Accidental Overdose Death Review Panel, it began with a statute in 2021. And we had our first meeting later that year. So we're between our third and fourth year of meetings. It's a confidential group. Most of the appointments are by the governor, but from designated slots. So it is a really incredibly talented group of 15 individuals who can serve 3-year terms, and virtually all of them were reappointed, all but one. And they have physicians and medical examiners and policy people, public safety people. There's a sheriff, there's a chief of police, there's Commissioner Sawchuk's on there with us. And I think it's just so important that people understand that there's a group of people who go behind the numbers and do a deep dive into selected overdose deaths. We also have the statutory authority to review non-fatal overdoses, but we've honestly been so busy in these 3 years focusing on the cases we've been working on that were fatal that we've not yet had an opportunity to review a non-fatal case. One of the more important things that we do, in addition to looking at thousands of pages of records from schools, from hospitals, from every treatment facility, from OCFS. We have statutory access to all the records, which are confidential once we obtain them. Only the Attorney General can authorize us to put out any information on the panel, and this is the second publicly available report that we've done. But one of the things that we've done that's a little different than most of these panels that operate in some other states is that we also give the family of the decedent an opportunity to meet and talk with Dr. Springle and Shelley Yankowski. They're both on the panel. Dr. Springle is a retired addiction physician who's in recovery. Shelley Yankowski, as many of you know, is an affected other who lost both her sons to addiction. And so they obviously have the ability to strike an immediate relationship with these families. And more often than not, the families are not only willing to sit down and talk about their loved one, but anxious to do so. And I think it helps them feel that, well, maybe something good can come of this situation. We are staffed by the University of Maine team at the Margaret Chase Smith School, really doing an awesome job to abstract the thousands of pages of records that we have. And essentially what we are trying to do is take a particular case, and I'll describe in a moment the kinds of cases that we've been looking at and how those decisions are made. But the bottom line is that we're trying to say, okay, well, Johnny died of an overdose when he was 31 years old. What was Johnny's life like from the prenatal period through the date of his death? What was the trauma that he might have gone through? What did he have adverse childhood events? What kind of family situation was there? And of course, you know what we find, that almost all the cases that we look at, the addiction was very rooted very strongly in youth, families, childhood, trauma, adverse childhood events. The first 5 cases we looked at were individuals who had just gotten out of incarceration. Then we looked at some cases where people had been recently incarcerated. And the 3 cases that we're going to be talking about today, we looked at adolescent deaths. Fortunately, the adolescent deaths that we have a very small percentage of our overall overdoses, down in the 1 to 2% range. But of course, they're shocking when they occur. And there were 3 deaths that we reviewed over about a 2-year period. Deaths occurred, a 14-year-old girl and 2 15-year-old boys. A lot of these deaths, the individuals were not really even old enough to have acquired an addiction, frankly. But I'm not going to set up the conversation that Dr. Carmack is going to have with you on what we learned from these cases. But we did want to make this information available. The Attorney General gave us the authority to do that. We presented the report to 4 different legislative committees: Health and Human Services, Criminal Justice, the Judiciary Committee, and the Education Committee. So I think that's, I'll close with, again, really thanking the 15 people that every other month spend 3 hours together by Zoom to review a single case, but in fact have spent hours and hours of time prepping for that meeting by just reading the abstract that the university team has prepared for us. So I want to thank our team. Dr. Carmack and the individuals that she's invited to to comment on some of the recommendations um, that are made. It says my internet is now unstable, but I'm hoping, Kristen, you would at least been able to get me to this point. Good. Adrienne, I'm turning it over to you to talk about the recommendations that we always make following the review of each case. And thanks you so much for doing this.
Thanks, Gordon. You just rose for like the very one phrase barely, so you made it. Thank you. And it really was an honor to be asked to be part of this. I think I looked back, I think it was November of 23 that the panel asked that myself and at the time Associate Director Bobby Johnson of Child Welfare, we were asked to be to comment on I think it was one of the adult cases, but then the adolescent cases were starting, so the panel asked us to stay on. So been involved since that time. And so what we're going to do is actually go through the recommendations, and I'm keeping it in the order that the panel chose to put it in the report. So I'm just going to share my screen to get this up and going. And Kristen, if you could nod that you've got it. Okay, great. So as Gordon said, if we want to, I think if we wait, or maybe it was Kristen said, that we would wait till the end for questions, but I do want it to be a little bit of a discussion. If there's something that some members who are on the call want to add to the conversation, we can definitely do that. So and we have Dr. Hagler here, who she is from the Maine AAP chapter. That's the American Academy of Pediatrics. And Dr. Hagler has been involved in a lot of the work that has been happening around helping to educate our providers in Maine around caring for youth with adolescent substance use, but also could comment because some of the recommendations talk just specifically about screening and touch points with our youth. So as Kristen said, neither Gordon nor I have any financial disclosures to make. And Gordon went over the initial sort of purpose of the panel and what the membership's made up of and how we do these recommendations. So I hope you get a chance to read the report, and we'll include a copy of the report in sort of, we're going to pull together all of the recommendations and anything that is in the chat and a copy of the report so you can read it. Actually, the team at UMaine has a very well written report, and reading it really is educational. So on top of sort of the recommendations, it's also just really hearing what they had to say. And there is an introduction piece in the recommendations around adverse childhood experiences, and kind of just helps people to understand how we can see that adverse childhood experiences can go on to affect people throughout their lives. And a lot of work is happening around trauma-informed care and how we can help build resilience and really focus on positive childhood experiences for young people and how that can be protective going forward. So there's sort of a little introduction about that before they get into the actual recommendations. And then it was decided to really try to, after we did all the reviews, we reviewed the 3 cases, in-depth reviews, and then there were recommendations that would come out throughout the time of reviewing the cases. And then we had, I think there were more than 29 recommendations. And so then the idea was sort of to group them and put them in sort of a organization way so that the report would have some organization to it. So the categories are the screening and assessment, and then looking at school-based recommendations, which actually a little bit overlap, and then around public awareness and outreach. And again, there's a little bit of overlap. And then there were some that we weren't quite sure which category to put them in. So those got put into the miscellaneous category. But they all sort of have a overreaching sort of sentiment of really how can we connect with our youth? How can we have times to really don't miss an opportunity to when a youth is reaching out or when families have needs, maybe basic social needs such as housing and transportation. Those are times that we can connect with a family and make a difference at all of these different times when a lot of times when they connect with the medical community or the school community, these are opportunities to offer resources and build our strong families. So we'll get started. Let me get my. So the first was around strengthening connections to social services and really hoping that when medical offices can see a family when children are in for well visits, when they come in for an acute visit, that's an opportunity to have, whether it's care coordination or whether it's medical assistants, have screenings that happen. Don't miss that opportunity to connect a family to social services. And a couple of programs have started within the state to help a family, such as Help Me Grow, Be There For Me, are two programs that have gotten started since the time actually of one of the initial deaths that we reviewed. Quite a few programs have gotten off the ground. So as we continue to make those available to families, it's important that we don't miss these opportunities when they come in for well visits, medical appointments. And so the next one is considering a live needs assessment mechanism, meaning that there might be, if people call 211 or they call Help Me Grow, and realizing that these are live connections to a family, that if there is concern when they're talking with the family, that they might be times that there is a concern raised on those live calls, that they could then connect to outreach, connect to resources that we have around SUD, resources that we have. So making sure that when these live 211 type call or Help Me Grow or any other sort of 988 call, that they can assess the needs of a family and connect them. So the group felt like maybe this should be possibly something that the Children's Cabinet could look at, or medical offices think about how they could do this outreach. So I think I can't quite, I can see that in the chat. Let me just see that. Yes, so Gabby is putting, great. Gabby put the full report so you could follow along if you wanted to. And then she put links to Help Me Grow, Be There For Me, and 211 and Access Maine. So those are all resources that have live outreach specialists that answer the phone and can really help connect families to resources. So the next is about screening and assessment. So these were specifically speaking to general mental health screening that should happen, and SUD screening. The first one talked about actually in the schools, and then the next is at well visits. So I didn't know, I was hoping maybe Dr. Hagler, if you wanted to just comment on how in the regular well visit, we actually do screening. But I did see in a recent article that came out that it's not happening in every medical practice and every primary care provider. I don't know if you saw that same article in JAMA.
I haven't seen that, Adrienne, but I know it's not consistent. But, you know, our practice is screening our 12-year-olds and older for depression, substance use, and anxiety pretty routinely. And just two things, and the AAP does recommend that we at least yearly screen for depression in our adolescent population. But there's and now to consider screening also for anxiety is another new additional recommendation. But what I was going to comment on is that the workflow of the office is really important, and all the screens need to be addressed, whether it's a positive or a negative screen. Just in working through various collaboratives and listening to many adolescents, sometimes the screen isn't really addressed, and that has its own message back to the people that you're screening. So time flows are challenging in primary care, but it's vital that those screens are addressed. And I'm going to plug the Maine Pediatric and Behavioral Health Partnership here and say there's a great resource at your fingertips. You know, if you have a challenging screen come back or you're not sure what to do, you can email or call through a portal system, or just pick up the phone and call and get behavioral health help support, either from a social worker that can help with resources or can arrange to have a psychiatrist talk to you, or on the website. There's a host of information and referral and guidance information as well. So I'll just leave it for that, but just want to make sure at one of our substance use conferences, an adolescent had commented that he had spilled his heart on his screen and nobody had really addressed it. So from there forth, he didn't say anything on his screen that was relevant.
That's really important what you're saying, because they really are really thinking about what to put. Like, I've seen kids like draw a line like between the answers because they're not exactly sure, and it's so important to them that we actually acknowledge their screenings. Yeah, thank you for sharing that. And then I know the school-based health centers, Sheila Nelson is on from CDC, and the school-based health clinics are also doing screens, and they also take the time to go over the screens with them, because it's separate from a well visit. It's actually the rapid adolescent prevention screening, which has a lot of other sort of areas that they're screening as well. Is there more you want to say, Sheila? I know Sheila's on too, if she wanted to mention what the schools are doing.
Yeah, so you're exactly correct. So school-based health centers do an overall health risk assessment that really gets out a lot of both, social stuff for young people, but also other health risk behaviors. But we sort of use that as a jumping off point to then go into more specific screens, depending on what a young person has said. So we had a number of school-based health centers recently who really piloted a very explicit use of the screening, brief intervention, referral, and treatment model, so the SBIRT model. And that was great. I think, all of them do some of it, but it was a really great way to get them just sort of to be very intentional about sort of stacking our screens and making sure that all young people that they see do get some sort of, screening.
Great. And also then having resources available. And so that's another piece, is if you're doing the screen, you need to know what resources are available. And Dr. Hegler and team put out all of these resources through Treat Me. And then, so Treat Me was a collaborative program that had a lot of educational resources and webinars and trainings, but now they've cataloged it all and it lives on a website. And then Children's Behavioral Health has a website that is full of information as well. So we don't want people to be afraid to screen, which used to be sort of afraid to screen because they didn't know what they would do if it was positive. And we really want to make sure that people know of all that is out there to help our young people. And within the recommendation, there was talk at some of the panel groups, like, should they be screening at the Y, and should they be screening at all of these different places. And sometimes it's really good, like, to make sure we're doing evidence-based screening and not sort of making, not screening everywhere, because that maybe not be what it has been shown to be recommended. But having some of these places where the youth are and go, aware of what resources, if a youth shares with their coach or shares with their camp counselor that they're struggling, making sure that resources are available. Same with the school nurses. And Tammy, I'm gonna let you put your facts in a little later, your links about because we have one around naloxone later on. So, but Tammy's here from representing our school nurses as well. The next one on this was about making sure at routine wellness checks that screening happens. And I think we saw that the youth did come for visits, but there wasn't always documented that there was screening. And there was an article, sorry to put you on the spot there, Deb, when I said, did you read the article? But in JAMA, there was an article that talked about like only 59% of primary care providers are screening adolescents, which, like, I think that we do, but that's part of our practices. But there's a lot of youth are kind of seeing all kinds of providers for their primary care. So we just have to remind every level of care that's happening to make sure they're screening our young people. And then a lot of conversation happened about what to happen if there is a positive screen. We don't want the youth to then think that they're not going to be able to be on, involved in the sports or the club that they want to be involved in. If they answer a positive answer, what will then happen? Will they then not be able to be involved in the activity that they want to be involved in? So how to sort of not stigmatize the youth who answers positively to one of these substance use, how to keep them connected was one of the real, we spent a lot of time talking about it, because obviously for one of the youth, sports was an important part of his life, and another youth, camp was an important part of her life. And if they've answered, they may have not answered positive on a screen because they were afraid then they wouldn't be able to participate in these social connections that were so important in their life. So that's something that, like, we all need to think about. When we think about sports physicals, which is actually, I think, the next thing. Yeah. So the next one is about exploring opportunities for the seasonal sports screenings for youth athletes. So if we think about sports physicals, suppose, mom calls and says, we forgot to do the sports physical. Cheering tryouts are in 1 hour. Can you get her into your office? And so then cheering tryouts are going to start in an hour. You got to get through that sports physical. Is that the best opportunity to ask a youth if they have worries about using substances? Because they're afraid probably that they wouldn't, if they put on the screen that they've been using alcohol or using marijuana, they're probably worried that I'm not going to be able to try out for cheering. So trying to think what would be the best way to actually help our youth to be able to reach out for help when they need help, and maybe not tie it to whether you can do sports or not, so that kids will still get engaged in sports, get engaged in what matters, and not just sports, because, it may be music, it may be a club that they're really involved in. And how can we connect with the adults and mentors in those areas to help our youth who might reach out for help, and not stop them from being involved in the activity, keep them connected to the activity and connect them to help. And I think the young person that Dr. Hagler was talking about, like, he even answered positive but didn't get help, right? Like, so there's both. We want to make sure kids answer positively if they need to, and how do we get them connected to services? Another time that some kids are afraid to answer positively is if they're worried about their parents. They're worried about what will happen if what will happen to their parents if that's part of sort of the substance use that's going on. They're afraid to answer positively because they don't want their parents to get in trouble. I've heard some youth have that as a concern as well. So let me keep going. This next one, follow up with I'm on the slide that says follow up with the Department of Education to explore the appropriateness of alternative schools. So this recommendation came out, it was probably about a year and a half ago, but it is moving forward that there will be the recovery school in Aroostook County, and that it sounds like that will be rolling out for fall of 26. I think I have, Gordon, is that correct? Is there that's moving forward?
That's correct.
Okay, I wanted to make sure I had that information. So that was one of the recommendations, but it did move forward since these recommendations were put out. So the next one is about the school-based health services as an access point for evaluating need and also giving our school nurses resources, so that because they are a place where youth feel comfortable, many youth come to the school nurse. Pretty often they are a health provider that is right there for our young people. So Tammy, I didn't know if you wanted to comment on some of the things that you've put together. Tammy works with our school nurses and she's with the DOE.
Hi, yeah, thank you. Yeah, so what we really recognize is during the 131st legislative session, one of the statutes was updated to include a requirement, and this is going to be more related to the naloxone, the requirement for public schools to offer training to secondary students on the administration of naloxone. And what became clear is they needed a little more support in how to implement that in the classroom. So we've worked really closely with DHHS and together developed a toolkit, and I'm going to pop that in the chat, along with a training that is almost ready. The toolkit is already available and is published online, and you can access it through this link. Sorry, I didn't make it pretty. And the toolkit covers carrying naloxone in schools, as well as legislation related to it. It talks about harm reduction, and then, of course, emergency management. We talk a little bit about effective communication and avoiding, stigmatizing language and things like that. So it's kind of a well-rounded, and then we also offer classroom and community teaching resources as part of that. So that's something to check out. And then coming soon, very soon, I've been promised like next week, hopefully, there's going to be a training available as well. And is screening in schools for the school nurses. I like that. I believe I read in these recommendations that there was expansion of screening practices and also consistent screening practices, which we really, in the school nurse's office specifically, do not have consistent practices there. So that's another area for growth.
Thanks, Tammy. And the other comment that was made is how nurses, teachers, and the adults in schools are a reservoir of adult mentor relationships. But I think we need to remind our nurses how they are really a positive adult that can make a difference in a young person's life, and just remind them of the value of that, of just being there and listening to our young people and being a positive adult can make more difference than they even realize. So give them kudos for showing up there and being there every day,
Yeah, 100%. That's something that we really have done a lot to kind of empower them, because they're often the first person and have a really close relationship with students. It's a safe place for them to share things. Yeah. So being able to have that language and open up communication so that they can share things that they might not share in other spaces is really important.
Great, thank you. Then the next one was about supporting evidence-based prevention tools for youth. and talking about sort of how there's programs within DOE, the Maine Prevention Network, and many of the after-school community-based initiatives, and how it's so important that these be available. And what we did notice also, though, is that some of the youth actually, because of housing instability and moving from community to community, they may not have actually engaged in some of these resources. So just making sure that they are available. I know that's one of the missions is to, the governor wanted there to be sort of prevention in every community attached with every school. So hoping to continue that so that we really have evidence-based practices in each school community that can reach our youth. I didn't know if there was any, Sheila, if there was any more on that, or feeling like nope, good. Okay, I'll keep, sorry. Okay, we'll keep going. Okay, so then we're gonna switch to the role of social media. And the role of social media, one, was noticed in really being aware of how much, not just social media, but technology, smartphones, being online, and our youth being exposed to the access to substances, drug trafficking, just through sales that are online, realizing that Snapchat, Instagram, all of these places are places that our youth are. One of the youth, like, when the overdose had occurred, kids were Instagramming one another and Snapchatting, like, as opposed to getting help. Like, it was just so something to read the story. But so one, understanding that social media is such a big part of our young people's life. And so then thinking about how can we harness social media in order to get messaging out to our young people. So those were kind of two things. And we've got Options, which does a lot of messaging and things is around prevention and treatment, but how do we actually get to where the young people are? And that shifts also, like they may be on YouTube, they may be on TikTok, they may be, just how do we make sure that we can get some of this prevention messaging and access to treatment out there to our young people? And how the Maine Prevention Network, drug-free community programs are all really trying to make sure that our resources are out there, but we want our young people also. So Gabby's putting in the chat, actually, the Options program, but also she put together, our children's behavioral health team put together RAC cards. And yesterday we were at a child welfare conference, and on Wednesday we were at a young youth in foster care conference, and had tables that had these cards that were made for youth that have information about that have QR codes on them, and you can get them through the prevention store, that actually give information for adolescents or for adults who care for adolescents or for providers that have resources for our adolescents. So those are some things that we definitely can continue to spread to get to our community. So the next one was thinking about making sure that the messaging that gets to youth is appropriate for their different ages. We've got actually yesterday when we presented, someone asked how young at what age should we start having conversations with young people, and at what age to start screening. So really thinking about the different age groups that people work with and what the messaging should be for those different age groups. So how do we get that, have that available for our providers, for our community prevention work, making sure that we can even talk to our young people. So the next one was expanding the educational messaging around overdose response for children and adults. So this, again, touches on what Tammy talked about, that in the school, we now have training for naloxone use. There's trainings for responding to an overdose, making it part of like basic CPR, having a conversation about overdose response, taking away the stigma of having that conversation, talking about having naloxone available. And so really normalizing this so that people will have naloxone available so that it can be used. And lots of different ways that you can actually get the training and have can get naloxone in the community. So there's another website, I don't think I shared this. I didn't have this one on the list, Gabby, but getnaloxone.org gives you places that you can access naloxone in the community. So just making sure that we keep getting the messaging out there for public awareness, and making sure that places where young people gather, or all the public gather, that there is naloxone available. Just like there's an AED, make sure there's naloxone as well. And the next one talks about when a tragic overdose death occurs, how then can that community sort of, one, come together and be able to support one another, and then help to get the message out throughout that community. Use that sort of at that time. There could be opportunities for the community to learn about drug use, about overdose prevention, about naloxone administration. All of these things, maybe resources may be more available in a community when a death has occurred, so that in case there's other youth that then, in response to the tragic loss, have struggles themselves. So sort of like what happens with the post-vention sort of supports that are available after a suicide occurs in a community, have similar resources available for a community after an overdose. So many times we see, but hopefully it's improving, but sometimes after a death happens, people are not out there sharing, their concerns or support to the family because it's an overdose and people don't know how to talk about it or what to say. And so really helping the community to support the family and the parents who may have lost a tragic, from a tragic loss. Okay, Gordon has put some things. Thank you, Gordon. The next one is, again, talking with our youth about early use of marijuana and then polysubstance use. Each of these, this again has been brought up at some of the conferences we've been at lately, that, because we have recreational marijuana use in our state, it's just out there in the community more. And so our adolescents see adults using marijuana. And how do we help to message to our youth that their brain is still developing? There's risks to starting substances at an early age. And how do we, without sort of using fear tactics, have really good conversations with our young people to help them to understand the risk of using marijuana, and then the risk of some of the substances that are mixed in with marijuana or maybe in the supply, and how to have good conversations. So again, resources about that are available in our community, and having that conversation is so important for our young people. So there was concern, like Gordon said, a couple of the cases, there wasn't like a long-term use going on with our young people. Some of them were just what we might say experimenting or trying, or had one bad pill. And as we have learned, one pill can kill, and that messaging is out there, and how the risk of some of the substances that are available, some of the drugs that are on the street, are actually laced with fentanyl. And let's have that conversation with young people. So the AAP has put out guidance when we do talk to young people at their well visits and start talking about substance use. Really don't avoid this conversation. Talk about the risk of fentanyl. Talk about the risk of what is available in the substances that are on the street per se. So there was there's now what's called the New Drug Talk, and there's a video and a website that is put out by this organization called Songs for Charlie, which actually a family out of California has really gotten involved in this after losing their son Charlie, who was he was soon to graduate from college, and actually used one pill one night, and that pill had fentanyl in it, and they lost their son Charlie. And Charlie was a friend of my nephew's, and I when I was looking at the website yesterday to get ready for the presentation yesterday, I saw that my nephew Jack is on the board of Songs for Charlie. So I texted him this morning just to fact check, make sure I was still up to date, and Jack is still involved with Songs for Charlie, a Song for Charlie, and they are very involved in this organization that is helping states have resources for having conversations with young people. And so again, thank you, Gabby, for putting that in the chat. But these are resources for this messaging around the risks of the drug supply. So next one is making sure that our youth organizations have support and opportunities to collaborate and support together to help our young people. Like we saw that, like I mentioned, one of the youth was pretty involved in her summer camp, and just helping the staff at camps to have access to resources like we're mentioning today, making sure they know where to turn if they have concerns about a youth, and all of us sort of collaborating to make sure that youth-focused programming has access to resources to help our young people, and to have access to naloxone and have training in overdose response, because we need to have naloxone available where youth might have access to substances. So just making sure that we can have these conversations. The next is also to consider, this was similar to the recommendation around helping a community after a tragic loss. Just again, having a program that can respond when an adverse event happens, such as a loss to an overdose, helping that community have a response. And when we were talking about this within DHS, this is something like there are the crisis receiving centers are in some of our communities. They have resources. Our recovery centers have resources. There's the certified community behavioral health centers have access to resources. So if, when a tragic event happens, if some of the other youth are having a hard time, there are resources in the community that can help sort of the response to that, and helping it, it may happen when school's not in session. So how does the community pull together after an overdose happens to help the other youth? So the CDC works with NAMI around after a suicide event happens. So helping our communities to know that these resources are available after an overdose event happens. So we're getting close to the end. So we also want to talk about that it was a recommendation that general assistance access throughout the state should be available when families need that, and making sure that families know how to access general assistance, and making sure that things such as housing, food insecurity, transportation, all of those resources are made available to families, because those can be a barrier to treatment. And we just saw a pattern of those needs not being met in some of the families where these young people who experienced a tragic death occurred. These were concerns that the families had. The next one was talked about opportunities for alternative paths to accountability, and similar to how do we support, there's a lot of conversation in child welfare around how do we support families before child welfare having to step in. This is similar. How do we support families without it being a criminal prosecution for if there's substance use for a young person? Like thinking about ways to have restorative justice, supporting families. So again, they're not involved with the criminal justice system and they're not involved in the child welfare system. How can we go upstream and help our families? So that was one of the recommendations, is to explore opportunities for that. The next one was again around food insecurity. So the recommendations in this section sort of jump around a little bit, and then we're getting to the miscellaneous, which also jumps around. So sorry, but the next one was actually we've acted upon this, that making sure that when there is testing for substances in the emergency room, that fentanyl is being tested for, because there was this was noted probably back in 22, 23, there were a couple of cases within some of these reviews where an emergency room might order a urine drug screen, but it was when fentanyl was first being seen and fentanyl wasn't on the urine drug screen. So making sure that fentanyl is being tested for. And this, as the drug supply changes, we need to know what to be testing for. And actually, one of the speakers at the conference yesterday, at the child welfare conference, talked about some of the new substances aren't being tested for because the tests aren't, the substances are getting out there ahead of what the tests are. So just trying to stay up on that. And actually, I think at the opioid summit that's coming up in 2 weeks or so, one of the keynote speakers is this great research provider that's down in North Carolina, from Maine originally, but his lab is able to kind of be on the cusp of what's being used on the street. They're figuring out what substances are being used, so that then that can help sort of inform our treatment and help inform our testing that happens. So the next one is to seek to keep children with families and wrap families with services, which is like what I was just saying around in the work that happens within child welfare around prevention. We really want our families to be safe. And if we build strong families, that keeps children safe. And that, again, I know we put information at the beginning of the chat, the child safety and family well-being plan is out of the governor's office and the commissioner's office, that we're working to really identify areas where we can support our families to help keep our children safe. And so this was brought up as a recommendation to support that work that is happening, because we know when children are raised in strong families, the children can stay safe, and hopefully there will be less substance use. The next one was about sort of back to that idea of, if a youth discloses that they're using substances, how can we support that youth and not suspend that youth? This comes to mind is the use of vaping in schools. Sometimes when a youth gets caught vaping, then they get suspended, and then they're home with their vaping. How does that help? So let's think about how we can connect youth to services when a substance use is identified, as opposed to suspending them or expelling them. How can we work with restorative justice? And I think we have some of that. So we're almost to the end. That I want to, if people have more comments. The last one was around that we not only should we look at the youth who we have tragically lost, but also the when overdoses happen, that a death doesn't occur, but could we get information when EMS goes to an event, or it happens at school, or where these overdose events happen, how some of that data that we learn from those events could help inform the work that we have going forward, and what outreach we could have with when these events happen, that can help us to provide more services as needed. So that was the last, that was a lot of information, I realize now as I'm saying it. So I'm going to stop sharing. And I see we got a lot of great information that people shared, which is wonderful. So I didn't know if anyone had any questions or comments, and We got through all of them.
Yeah, thank you so much. And thank you, Gabby, for sharing so many resources in the chat. And we'll try to compile those for folks too. So we can send out a list of all those links. There was a question from Charity who asked, what is the recommended age to begin screening for risk factors on SUD in adolescents in primary care or other settings, I suppose?
Yeah, I see. So Deb, you want to?
Yeah, Deb.
Yeah, you can start very, very early. I mean, most practices will start around 12, but it starts much younger in some, in honestly many cases. I've had kids very, very young tell me, I think my youngest patient had started smoking at age, I can't remember if it was 4 or 6, but picking up butts left over from around the home. But there's not a standardized screening tool for younger kids available. But many, many people will start to use the craft around age 12 with adolescents. And I was just going to comment on the setup for the office is really important to make sure sort of there's rules of the road that the adolescent understands. About confidentiality and when you're going to disclose that, because that will help you get more information and establish a better relationship with that adolescent beforehand. So if that's all laid down before, and making it clear to parents that you really want to have the opportunity to talk to the child alone, it's it's really, really, really it's really important. And you're the caregiver and the parent knows the child and the child has a degree of comfort. So you're going to work through that and you have a relationship hopefully with the family. That's the nice thing about primary care. And the AAP has some really good guidance around confidentiality in the primary care setting with adolescents. But you'll establish boundaries and a much better relationship if that is sort of if the rules of the road are laid out, what the rules are around confidentiality with screening with around substance use. But using a standardized tool is better. And honestly, there's more data around using it with a computer can sometimes be even better because they feel less judged and they need to do it away from their parents. Like there's a whole litany of best practices around doing the screen itself.
Thank you so much. I know we are at our time here, so I want to be respectful of everyone's time, and thank you again to Dr. Carmack, Gordon, and Dr. Hagler, and Sheila, Tammy, and everyone for joining us today. My colleague Casey did put a link to the evaluation in the chat for folks who are looking for a certificate for today's program. You can find that link in the chat, and that will also be emailed to you. And we'll also, as I said, compile some of these resources to be able to share with everybody who joined today. If you have any other questions or you can't find any of the resources that were mentioned or you want to follow up on things, you can always reach out to us at the Maine SUD learning community and we can connect you to somebody who can get that information to you. So thank you, everyone, for joining us today. I hope the rest of your Friday afternoon goes well and hope to see you again.